and he's going to talk on phacoemulsification in corneal ectasia.
Good afternoon all. So I'll be discussing the surgical challenges that somebody encounters while doing cataract in a corneal ectasia or more specifically keratoconus patient. So what are the challenges that you have in such patients? The most important is biometry. Remember in keratoconus the relationship between your intercorneal power and posterior corneal power is changed. The cornea is bulging. So if you use an axial length measurement method that depends on contact method, again you will get a wrong estimation. So the preferred method of biometry in such patients is IL master or any optical biometer. Now, which is the best formula? So there is a lot of debate, but recent literature suggests Kane keratoconus formula is probably the best one. This is an article from American Academy of Ophthalmology. If you look here, the least error or the least residual error was with Kane's modified Kane's keratoconus formula, which was 0.8, then SRKT, then Barrett's Universal 2, then unmodified Kane, then Holiday 1, then Holiday 2, and Hygis and Hofer-Q come subsequently. So this is probably, as per the current literature, best formula to use. Now I'll go through a video to discuss the other important points that you should remember in keratoconus and cataract. So limbal entries. Why? Because cornea is thin. If you make a clear corneal entry, then that may not be self-sealing, and you may have to put sutures. So that is one. And second, when corneal wound heals, it may induce some astigmatism itself. So it's always better to go for limbal incision. Staining the capsule is must in all such patients, because although the cornea appears clear, but there will be a lot of distortion when you are taking your instruments in, and that I'll just show you in one of the subsequent steps. As you can see here, the rhexis is attempted, but when the rhexis forceps comes here, you will find there is a distortion. Okay, so that time if you haven't stained, then it may be difficult. So from when you are taking the your instrument in the cone area, then there will be distortion. So to take care of that, you must use the rhexis forceps and don't leave the flap at any point of time, and stain the capsule. Then rest of the steps are similar to phacoemulsification, but one thing to remember is, there may be some difficulty in depth perception. You may be feeling that my PC is quite behind. On the contrary, it may be very anterior, and you may land up in rent if you are not careful, because the cornea is irregular, and depth perception stereopsis both are affected when you are operating using the microscope. And this is conjunctival ballooning. If you do a limbal incision, this is bound to happen in most of the cases, but nothing to worry. Just give few relaxing tenotomy incision, that will be taken care of that. And the bag size is usually big in such patients, and so the nucleus pieces may not come easily to the phaco handpiece. So what you can do is you can inject some viscoelastic and bring those pieces near your near the center, and then you can complete your phacoemulsification. And another important thing that you should remember is, in such cases there may be hidden pieces. Pieces may go into sulcus, or it may be in the angle, and when you feel that your surgery is complete, then somewhat suddenly one piece may come. So do a meticulous IA and do it for little bit longer time compared to your routine phacoemulsification. So these are the few practical tips one should remember while using this. And personally, I would always prefer to put a suture. However, if you feel that your wound is healed, it's self closing, then you may not it may not be required at all. So this is a case of keratoconus with PMCD, with hydrops, with little bit corneal scar. The surgical procedure is similar to the previous video, but except one thing, remember, always try to avoid the scarred area. Don't make your incision through the scarred area, and even if you are making the incision, it should be perpendicular to that. If you make incision along that, the study suggests it may induce more astigmatism. If you have a microscope integrated OCT, that may help you little bit, but it's not mandatory. Even you can do it without that. Rest of the steps are similar to the previous case. Stain the capsule, use a rhexis forceps, be careful about distortion of your instruments, and be careful about the depth perception. It may not be exactly what you are thinking. So this is a paper which me and Dr. Namta have published about phacoemulsification coexisting corneal opacity. You can go through that. It has all the practical tips for doing that. So just to summarize, what are the difficulties that you may encounter in corneal ectasia? The most important problem is probably visualization. Why? Because there will be light scattering, there is difficult depth perception, there may be corneal scar, and the cornea cone junction may cause a lot of difficulty. So how to bypass that? Use trypan glue, use viscoelastic, that improves your contrast little bit. The second problem is where to put your incision. I have already told that always try to avoid the scar area, go for limbal or corneoscleral tunnel. And if you feel that the incision is not self-sealing, always put a suture. So this is a paper by OE et al. Where they use RGP lenses. If you see the first picture, without RGP there was distortion, but the moment you put an RGP lens, it becomes more focused. So this can also be used while doing surgery. This is a Jarrett protocol, which suggests how to approach cataract in keratoconus patient. Remember, first ensure if the if the keratoconus is stable. If it is stable, go for a toric IOL. If there is regular astigmatism, if it is not there, go for a monofocal IOL. If it is not stable, you can use all the methods like CXL with Intax to achieve a stable keratometry. Once that is achieved, again you can plan IOL accordingly. But in advanced keratoconus, it's always better to go for a triple procedure, that is keratoplasty with cataract, or you can plan surgery. The keratometry that you should take is standard K, that is 43.5, instead of taking the keratometry of the patient. Before I conclude, this is a patient who has referred to me with a vision of 618, right? And the diagnosis was the patient is having cataract, so that could be the cause. But when I examine the patient, you see he has all the features of Bardet-Biedl syndrome with retinitis pigmentosa, short stubby fingers. So remember, all the cases of keratoconus or corneal ectasia, the poor vision is not because of your corneal opacity. There may be some associated condition. So do a thorough workup and then plan for cataract surgery. With this, I'll conclude here. Thank you very much.
Thank you, Dr. Prafulla, for the wonderful presentation and very important tips when you are dealing with the corneal ectasia and the cataract.